right, and welcome to episode 12. I think we're at 12 of BurnCast, and happy Burn Awareness Week. We may do a little bit about prevention at the very end because that's what Burn Awareness Week is all about. But today we have the exciting opportunity to have a special guest, and it's Marie Ritzo. She is one of our social workers here at the hospital. And of course, we have Anne and Liz and myself. And you guys know us well enough now because we are on episode 12, and we all know you've watched all 11 episodes before this one. So first, Marie, tell us a little bit about yourself and about being a social worker with trauma and burn.
So I have been working on the trauma service now for at least 12 years. I don't know exactly the date that I started, but I'm a clinical social worker licensed in the District of Columbia. I work with patients who come in having been injured either accidentally or what we call non-accidentally injured, and that's child abuse. I work with a terrific team. We see children who've been accidentally burned, sometimes unfortunately intentionally burned. We work with child welfare in the various jurisdictions, and my job is great because I feel like I'm a point person who interacts with the various medical disciplines, all of which I think are outstanding here on this service, and the outside world in terms of arranging to meet the psychosocial needs of the children we see.
And for our burn patients specifically, do you meet all of our burn patients, or like when do you get involved with our burn patients?
So when I first started this job, one of the things I wanted to happen, and which has happened, is every burn patient who comes in is assessed by a social worker.
No matter what the age?
No matter what the age. I mean, in the emergency room, if the child is under 2, that's an automatic emergency room social work consult.
And why is that?
Just to make sure that safety issues are evaluated and addressed. And when the child comes up to me, I have at least that much of information, and I can start talking about what else the family needs to make the medical intervention successful.
Oh, so you see every inpatient burn, but not every burn that comes through the hospital.
Right. I'm sorry.
Okay. Okay. And then, so do you go and see them in the PICU, or do you see them once they get to surgical care?
I usually see them once they get to surgical care.
Okay. And do the social workers in the ER for like the younger kids, do they like give you like a overview of like what's going on, or like is there some way that that's tracked, or like
right? Yeah, we have a communication system set up with the social workers in the emergency room, both during the regular hours and then the after hours shifts, the evening and the overnight shifts. And they report on every child that they've had an intervention with in the emergency room. So I get a list every morning of who came into the emergency room, who was seen by social work, what the social worker's quick assessment has been, and what the follow-up needs are. So that's all communicated. And then we, together as a team, the burn team, and we look at every patient on a weekly basis too, just to make sure we're not missing anything.
And when you say we, like just like, are you talking about burn rounds?
We're talking about burn rounds. We also have rounds that we call child protection rounds, where we look at patients who come in who may or may not need a referral to child protection. We evaluate whether the child was assessed accurately and whether a report needs to be made or not. And we follow up with those patients as well.
Are those like when you say you see every kid on surgical care, is that part of like the order set, or do people have to remember to consult you, or are you just like everywhere and know where everybody is?
Both. I think that, I don't know. I mean, I know I get consults on burn patients who are admitted. So you'll have to ask somebody like Anne on how that's generated. But I think that it's sort of a matter of course that, if a patient comes in with a burn, they ask for the social worker to see that child and family. And I'm reviewing the census every day and, who's on the unit and what's happened, and can tell if I need to duck into a room as well.
And what do you, can you add to that?
In terms of whether or not Marie gets consulted, when we place orders on our burn patients who are admitted, as long as we're using the burn order set, there's an automatic order for a social work assessment. And then if somebody kind of escapes that order set somehow, or the order doesn't get in, personally, my practice is to reach out to Marie for any patient who is a burn patient that hasn't already had a social work assessment, and to give her a heads up that they've made it to the floor, whether or not it's through the PICU or directly from the emergency department.
And what can you explain, like, kind of how you work with social work if you're like worried about like a discharge, or if you're not worried, or like how is social work, and like on your side, how do you view like the integration within the team?
I would say that Marie, or social work, but I'm just going to say Marie because she's our social worker and I have a dear spot in my heart for her. But Marie is instrumental to our team and she really helps facilitate. I think there's, we could go into a couple different buckets, and one of them is when Marie's working with child welfare, and kind of when she was talking about the non-accidental treatment or child abuse, there's a whole other layer of that. But if we're talking about a patient who had an accidental injury, just to get the support services that are necessary for the family. Many families struggle with an accidental injury. Many families, it's hard to end up in the hospital for days or weeks on end, and to be able to have whatever services can be provided, or to have assistance with medications, or the family's ability to be present in the hospital, or even sometimes just being able to kind of cope with what's going on. I think Marie is a great support for our families, and works well with us in that if there's a guardian issue, or a transportation issue, or a safety issue within the home, she communicates directly with the team. She works with the family, and kind of it's a very collaborative way to try and support our families.
And Marie, do you see that families of children that are burned, do you see that their needs are different, or anything that like our bedside nursing staff should be on the lookout, or if you, for some reason, if you haven't gotten there, like what are like some red flags that we should, our bedside nurses should look for, and just for our burn patients?
Well, in terms of coping, burns are tough because they're so visible and they're so dramatic in their presentation. And especially when you have a child who is burned on his or her face, it is really, really hard on the caregiver. There can often be some level of guilt over what happened. Sometimes there are family members who blame the parent who was there at the time. You may have a parent who's got a gazillion different pressures on him or her when the burn happened. So things just kind of fall apart. So, we have, fortunately, these kids recover well and relatively quickly from a lot of the burns. So it's encouraging for parents to see that progress. But I think initially it's really, really hard to be with a child that you see is in so much, has been damaged by that kind of thing, and is undergoing these various dressing changes and treatments that is very hard for a parent to witness. And just being with a child who's being sedated is hard. But having that happen repeatedly over the course of an admission for dressing changes is really tough.
How do you introduce yourself to parents? Because I feel like a lot of parents do feel like almost like a guilt if their child like accidentally gets injured.
Right.
And like we all know, like developmentally kids are like reaching for things and like
Right.
bad things happen.
Mhm.
But as you were talking about like the blame game of like sometimes like the one parent will be like, you didn't watch them well enough, and the other parent will be like, you're never around. And like I feel like a lot of our families sometimes like hear the word social worker and they think CPS.
Right.
And like how do you address that, and how do you
Right.
like introduce yourself and like what your role is to the
Yeah, I mean,
families?
sometimes I know I'm alarming to people. So I follow sort of two entry approaches. One is I normalize my involvement. I make sure they understand. I see all the kids who come in with burn injuries, that there's nothing particular, that there may be nothing particular about their situation that's got me involved. So that's number one message. And number two is that I attempt to join with the parent by saying, we need to make sure that, your child is getting the best care. Do you think this child is getting the best care possible? Do you have any concerns? Do you feel like you're being respected by the medical team? Those kind of questions give the parent the sense that this is not a threatening intervention for me. It's more of a, buddy, not a buddy, but, a partnership in terms of getting the medical care the child needs. And the third thing I do, and I do this really honestly, it's going to sound schmaltzy, but I do it honestly. I look at the child and I find something that I find charming about the child. And there's something, at least one, two, sometimes three things that are very charming about a child, and I note them to the parent. And I can tell you that there is no parent who can hear somebody say, he looks like he's a really smart kid who doesn't, develop with that,
Right.
And it's a way of joining the parent and not being a threat to that parent. So those are sort of my approaches to entering the room and calming things down a little bit.
When you ask the parent if they feel like they're respected by the medical team, what do they say? And do you ask separately from medical team to nursing staff?
I usually just say the medical team.
Okay.
And I would say people are a little surprised when I ask that question. Like it's like, oh, is that important? But I think they appreciate it.
Yeah.
And sometimes there'll be somebody like, nobody's explaining anything to me, that kind of thing, which happens. And we talk about that some, like, what is it that you need to know, and let me see if I can get somebody involved with to explain that to you. I mean, we're really lucky we have the nurse practitioners on the floor because they're very available and they're really excellent at communicating things. So we get that cleaned up. But I think the very question, are you being respected, for some people, I mean, nobody's ever asked them that question. So it is a way of, I want to know, of course, I want to know that they feel respected, but it is another way of establishing a connection.
What would you, is there anything that our team, and specifically our bedside nurses, is there any like hint or trick? I think you gave us like one just now about like truly looking at the child and the family in the situation and finding like 1, 2, or 3 things that you can like relate to their child and them with. I think that's a really good tip of like, if you're having a hard time connecting with the family, or having, sometimes we have younger nurses and people look at them and go, wow, some of my kids are older than you, like, and now I'm supposed to trust you to take care of my kid. Or like, do you have any hints or tricks or helpful things for our bedside nursing staff? Like, we know that if honesty is like a good thing, but
Yeah. No, honesty is really good. I would say the surgical care nurses are really spectacular at working with the families. I don't know that I could give them any advice. They seem to come at it naturally. They're young, and so they interact with the kids in a certain way that is constructive. And so I mean, sometimes you have difficult situations with families, but they're really good with the kids. So that goes a long way, not only with the child, but with the family as well.
What
I
about more in the
really think this
crisis
is
time, like in the ER
Mhm.
or in the pediatric ICU? Because those are two very different situations. Like the ER, their goal is to make a disposition
Right.
decision, treat, and either like send them home to follow up in our burn clinic or to go to the ICU. So those are like, you're either you're going a few places. And I think that the way that our nursing staff like interacts with the patient, it needs to be a little different for like acute crisis. But
Mhm.
once they get to surgical care, they've kind of come down from
Right.
that, like,
You're settled in. Yeah.
yeah.
Yeah. Yeah. I don't know. The ED is really tough because often people have waited a long time. They're hungry, they're grumpy, they haven't had sleep, they're worried, they're anxious, the child is not unhappy, and nobody can leave to get something to eat because you can't, you can't leave the child there and do that. So it's a totally stressful situation, absent the care that the child needs. So that's a pressure cooker. And yeah, I don't know how people manage that, to be honest with you. And then the ICU is another situation where things are just so intense. But the one-to-one care sort of allows for a connection with the family and the nurse that you don't get in the same way on the acute on the floor, let's say. So I don't know if that
Just do the best with what you have and be honest. And
right.
but I still think like finding ways to connect with the family with the child of
Right.
finding those little things could work for all three different situations.
Right.
I think the way I think of that is, sorry to interrupt your question. I
No.
think the way I think of that and probably how it relates to how as a clinician kind of that works and what Marie's saying is that we really all want what's best for the patient, and we're on the same team as the parents and the family, and we kind of at the end of the day we all want to work together, and sometimes it may not feel like that from many people's standpoint or from different viewpoints of being on the team, but I think in pediatrics families are part of the team and parents are a huge part of the team, and I think we try and do everything we can to help people and assist families and parents in, as Marie just explained, what can be really, really stressful situations. So it's hard, but I think trying to put yourself into the perspective of hungry, long wait,
Mhm.
one of the most stressful things to have your child injured, to have to look at that, to see them disfigured, if there are physical burns that you're seeing on the face, the bandages, whatever it might be. There's so many different variables, and that we just all want to work together. And I think if you can kind of put yourself in the shoes of the family or the parents, then it assists with your ability to connect with them.
It's also important to remember that this is not a relationship with the care providers that is going to just go away at the time of discharge. We follow these patients for a very long time. So they're going to continue to have encounters with the whole medical team at different parts throughout the rehabilitation process. So again, that this is going to be a long-standing relationship is something to remember as well.
And Liz, I don't know if a lot of people know, but Liz she sees all of our outpatient burns at the Friendship Heights Clinic and on telehealth. And not so much for Friendship Heights, but and you might be able to speak to this as well. In the outpatient setting, like how are we incorporating social work in the outpatient setting now?
I think most practically, if I have a question about, consent or something, again, kind of, more administrative, I would certainly, I would touch base with Marie ahead of time. But, I think it's also important to mention that we do continue to bring these cases up at our burn multidisciplinary rounds. So if there are social concerns, then that's a good forum to discuss what those might be, and again, to try to mitigate some strategies to help.
Marie, how often do you get involved with our outpatient kiddos?
Well, more frequently now.
And do you want to explain to everybody like why now? I don't think that we did a great job of like you've always worked with our kids on
Right.
Beast, but
Yeah.
now you're completely dedicated to
Yeah, now it's a dedicated position to the trauma and burn patients. So up until very recently, my job involved working with patients on different services outside of trauma and burn. And so that's how my attention and time was divvied up. Now I can focus in on these particular patients. So that means I'm going to be more available in the outpatient follow-up part of it. So.
And have you identified any needs for like outpatient versus inpatient? Do you feel like the families are in a better place once they get to outpatient, or not
Yeah, I mean,
always, or dependent?
Yeah, I mean, to some extent, I mean, it's always better to be home than to be here, even for those of us who work here. But it's so that's good. I mean, the problem is people getting time off from work to come in, people having to pay for gas and parking to get to and from the hospital. Lots of people don't have their own transportation. The Medicaid transportation, it can be a real headache to get established. These states are very stingy with the resources for Medicaid transportation. I mean, as an example, if you have a family who has a car that is not functioning, they won't provide transportation to that family because the family technically has a car. So you're kind of running through a gamut of obstacles that need to be taken care of. So it's hard for regular follow-up for those reasons. And a lot of employers are not that understanding about a parent's need to have the time off. So that's another big stressor for families.
Yeah, that I had no idea about the whole Medicaid and the car.
Medicaid is a total headache. Yeah.
Yeah, I had no idea that was I mean I always assumed that there was like a lot of like rules and regulations, but yeah.
It's really it seems like it's been deliberately set up to frustrate everybody, but it probably was. I don't know.
Well, I think that anybody who has ever worked in a hospital as a nurse or a provider understands and appreciates and values social work probably more than most specialties, because I feel like social work always comes in and fixes things. Like it's like, oh God, I don't know what to do. There's too many feelings going on right here. Somebody needs to call social work and help us sort this out.
Yeah.
Are there any misconceptions that you think nursing might have about social work? This is your time. Any misconceptions? We can
It's not
debunk
nursing so
anything.
much, not nursing so much. Honestly, it's more the doctors, especially the new doctors, who think we do things like home visits here, who think that we can find housing in a ridiculous housing market, who think that we can take care of things that, I think a lot of people come in professionally from not everybody, but a lot of people come in from comfortable backgrounds. And when they come into an urban hospital and they see the circumstances under which a lot of people live, they want to fix things to be more like their own experience or closer to their own experience. And so, sometimes, you'll get a referral and it's like, okay, this is pretty, there's no way to find housing for 8 people by next week, it's just impossible situations. There are not that many resources readily available to satisfy some of the family's needs, but certainly not at a level where they're super comfortable. So
What do you do in a situation? So say we have a family that has 8 people
mhm.
that you've been referred to. So say their kiddo was burned, and then you realize that there's 8 other people and they are all they don't have a, like, what do you do as a social worker?
Well, it depends on the jurisdiction that the family identifies for itself. I mean, it's not even 8 people. Sometimes we have people who come into the District of Columbia from another country. They're not really documented to here. They're not residents of the District of Columbia. And, those are really challenging situations because, the social services that might be available to a district resident are automatically eliminated because this person is not technically a resident. So it's really hard. You've got to really shake the trees very hard when those situations come around. And we have had people come in, kids come in with I'm thinking of one in particular who came in with a horrible burn from Nigeria. And she was here with her mother and her brother, and they had no housing. So that was a complicated situation that needed a lot of time on the phone and working with various agencies to get them tucked in, which they are. But
It doesn't happen overnight.
it doesn't happen
what you're saying.
overnight, and it certainly doesn't happen without a lot of my screaming on the telephone, with various people to get moving on things. So
Do you
Marie
know?
is a fierce advocate for her patients. I'll just say that, having worked with her.
absolutely.
I mean, I think everybody who's watching this knows that we are all like we are big Marie fans, and we'll
Yes.
carry the sign. We're like, we
Yeah.
love
Well, I'm
Marie.
big fans
Team
of-
Marie, Team Marie.
Definitely, we are all team Marie.
I need a cape. Yeah.
Oh, we should get you a cape.
Yeah.
How many social workers does Children's have? Do you have any idea?
Yeah, I think there are about 40 of us altogether, and that includes part-time, PRN, overnight shift people.
That's not that many.
No,
How many vacancies do you guys have?
we have a lot right now. I think.
How many should we have?
How many social workers should we have or vacancies, Cindy?
How many social workers should we
I
have?
think there's 7 or 8 vacancies right now.
Okay.
So I think there are about 7 vacancies.
Wow, I for some reason I thought we had more social workers. I mean,
Yeah.
you guys really are miracle workers. I think that there's so many of you, and they're really, I mean, if you think that like social worker to nurse ratio, that's insane.
Mhm.
Yeah, that structure, it's very small. Do you
Yeah,
guys know each
I mean-
other?
Pardon me?
Do you guys all know each other?
Oh, yeah. And we cover for each other too. We're set up so that if any of us take time off, we have to get somebody who will be responsible for our service or our responsibilities. So we do know each other, and we do know each other's services. So yeah.
Okay. Anne, what's the one thing that you want nursing to remember about social workers, and particularly with our burn patients, or just in general?
I think about social workers in general, if you don't really understand or you have a question and wonder whether or not it's within their scope, I think ask, right? I think we're all kind of working together, and then just think of ways that we may be able to assist families in incorporating this new hospitalization and burn injury into their life and kind of into the challenges of making them be able to support the child to get the treatment that they need.
Liz, what do you think?
I just keep going back to Marie's question to families, if they feel respected by the team. I think
Yeah.
that's so important. I think we all just kind of keep that in mind. And again, this is a terrible, terrible accident or circumstances that led the family to this hospitalization. And how do we, again, support and respect them and their child? So I will keep that in mind for sure.
Yeah, and
Yeah.
just tagging on that part, some of the families we see, some of the people we see, the parents, have never been listened to before in the way we can listen. And it's, I think we take it for granted, but it's a very powerful thing to be a person who, and I'm not just saying this about social workers, I'm saying this about everybody who's providing the care, but to be the person who really listens to someone who is not used to being heard. And we have a lot of people in this area who live under very, impoverished circumstances and who are not considered important. And so, when we make them important, I think it's a very important thing that happens.
I think that is probably the best takeaway. I think we've had we've had a lot of BurnCast, but I think that, as people that are doing bedside care, I think there's so much communication that we're trying to I feel like we're inundating families with things all the time. But I think that hearing what you said today is remembering that we have to listen to. Yes, we need to make sure that they're understand, that our families and our patients understand what we're doing and why we're doing it, but also really taking the time to listen at the same time and not be like, "Da, da, 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 do you have any questions? Okay, gotta go." We have an opportunity to make this better in a really scary time.
Yep.
And Marie, lastly, do you have any final thoughts?
Well, let's see, March is social work month, so.
Oh, yay.
So say hi to your social workers. Yeah, no, that's it. I mean, this, I say this all the time and it sounds schmaltzy, but it's really true. I mean, this is a really A1 team. I'm really privileged to work with all of you. And I really mean that. So, and I'm from New Jersey, so I wouldn't say it if I didn't mean it. So. Garden State girl. Yeah.
I love it. All right. Well, thank you so much for coming today.
Thank you.